Hello to everyone tuning in virtually. My name is Olivia Rice, and I'm from Atrium Health Musculoskeletal Institute. I'll be sharing some interesting findings regarding how BMI independently affects post-op patient-reported outcomes following lumbar fusion, even in the absence of surgical complications. As you may have inferred from the title, the topic of discussion today surrounds obesity and surgical outcomes. If surgical complications popped in your brain and you're starting to tune out because you've heard obesity increases surgical complications more times than you can count, stay with me for a minute because that is not what this talk is about. Logically, it makes sense that when a patient has a surgical complication, their objective outcome is jeopardized, or at a minimum, the patient's perception of their outcome is jeopardized, or both. Either way, patient-reported outcomes are likely affected by this, which we often use as a standardized means to measure surgical success and value. Obesity increases complication rates, and complication rates jeopardize postoperative outcomes. But does BMI past the obesity threshold independently drive patient-reported outcomes in the absence of surgical complications? And if this direct relationship does exist, does it vary with severity of obesity? The purpose of our study was to answer these exact questions. The Quality Outcomes Database is a prospective registry that collects demographics, surgical details, and patient-reported outcomes across spine centers nationwide. We retrospectively reviewed its contents for the study. We included adult patients who underwent 1, 2, and 3 level elective lumbar fusions for lumbar degenerative disease. All patients had at least 12 months of recorded postoperative follow-up. To assess obesity's effect on functional postoperative outcomes independent from postoperative complications, we excluded the 608 patients with adverse events within 30 days from surgery. A few specific postoperative complication etiologies are listed on the right-hand side of the screen. We also excluded patients undergoing surgery for high-risk indications such as infection, tumor, fracture, deformity, pseudoarthrosis, and paralysis, as well as vulnerable populations. In summary, our analysis cohort included normal-risk patients who underwent 1 to 3 level elective lumbar fusion for similar indications, all with objectively uneventful postoperative courses. BMI weight categories were defined using CDC criteria seen here. While we treated BMI as a continuous variable during analysis, our results are grouped by these categories for easier data visualization and clinical interpretation. Our primary outcome measure was the Oswestry Disability Index score. The ODI score is a commonly used validated patient-reported outcome measure used to objectively represent severity of lumbar back pain. A higher score indicates more severe back pain. All patients had preoperative baseline scores and 1-year postoperative scores recorded, allowing us to calculate the ODI change score, representing the relative improvement in back pain following surgery. We also analyzed patient satisfaction following surgery, which was measured using the NASS Patient Satisfaction Index score. A 2-step linear regression analysis was used to evaluate BMI's effect on 12-month postoperative ODI scores, while controlling for patients' baseline ODI scores, as well as additional confounding variables. Seen here. Prior to development of the regression model, confounding variables were identified using standard statistical methods and then controlled for. This included controlling for baseline ODI scores, thereby isolating the effect of BMI on 12-month ODI. A logistic regression model was used to assess BMI's effect on ODI change scores with MCID threshold criteria. In total, 8,171 patients were included in our analysis cohort. Okay, so what did we find? As you can see here, average baseline ODI score clearly varied as a function of BMI class, indicating that patients with higher BMI reported worse back pain prior to surgery compared to patients with lower BMI. The regression model was significantly different amongst BMI categories for 12-month ODI score as well, even after controlling for baseline ODI score. This tells us that BMI is a significant predictor of absolute 12-month ODI score after controlling for all other significant covariates. MCID criteria aid understanding of clinical impact. Recall the MCID threshold of 14.3 points for ODI change score. This graph represents the proportion of patients whose ODI score decreased by more than 14.3 points, displayed by BMI category. Logistic regression showed BMI was a significant predictor of ODI MCID achievement. The odds of lowering your post-op ODI score more than 14.3 points decreased by 2.3% per unit increase in BMI. These findings suggest there is a significantly lower likelihood for meaningful clinical improvement after lumbar fusion for obese patients compared to their non-obese counterparts. Finally, the percentage of patients who were satisfied by their surgery are shown here by BMI categories. Patients qualified as satisfied if they selected level 1 or 2 on their NASS satisfaction survey. Again, increasing BMI was independently associated with declining 12-month patient-reported satisfaction. Prior to this study, we questioned whether obesity influenced patient-reported outcomes independently or if the fact that obesity leads to increased post-op complications confounded that relationship. This study illustrates that at 1 year postoperatively, obese patients without surgical complications showed higher pain and disability scores, a lower likelihood of meaningful clinical improvement, and lower postoperative satisfaction compared to non-obese patients. Therefore, increased BMI or obesity is independently associated with worse pain-related disability and decreased effectiveness of lumbar fusion surgery, even in the absence of surgical complications. So, how does this information change our clinical practice? Well, it may be disheartening on first pass. However, we don't recommend excluding everyone with a BMI over 30 from elective lumbar surgery. Instead, this information should help guide preoperative counseling with obese patients in order to set appropriate expectations for symptomatic relief following surgery. There is also a potential opportunity to increase preoperative optimization resources as well, since BMI is a modifiable risk factor. In conclusion, when all confounding factors related to obesity and surgical outcomes are stripped away, BMI over 30 independently and significantly decreases the likelihood for clinical, meaningful symptom relief following lumbar fusion. The higher the BMI, the less likely the surgery will be effective. Thank you again for tuning in to my talk today. I'd be happy to take any questions via the email address listed below. Thanks and have a great day.